بسم الله والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. Today we are going to talk about beyond visual estimation and the new era of blood loss estimation in postpartum hemorrhage. We are going to move beyond the guessing work to improving detection and guided decision and save lives. بسم الله والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. Today we are going to talk about beyond visual estimation and the new era of blood loss estimation in postpartum hemorrhage. We are going to move beyond the guessing work to improving detection and guided decision and save lives. In this lecture, we are going to have a comprehensive approach to blood loss estimation with covering of why accurate blood loss estimation is matter and how it's reflected in the maternal mortality and morbidity. We are going to cover the method of estimating the blood loss, whether visual or quantitative method or combination, and the clinical indication for significant blood loss with maternal tachycardia, hypotension, and sign and lab investigation. And we are going to talk about the definition of postpartum hemorrhage, WHO, ACOG, FIGO, and RCOG. And we are going to talk about the shock index. What is the shock index? Why it is important? And what is the implication of shock index in the postpartum hemorrhage? Why accurate blood loss estimation matter? Because visual estimation commonly underestimated the true blood loss. Look to this picture, it look like 500 ml, but actually it is 1000 ml. Underestimation is common and the consequences are not. Delay recognition of postpartum hemorrhage increase morbidity and mortality, where quantitative methods significantly improve detection of excessive hemorrhage. Visual estimation underestimated the obstetric blood loss by approximately 30 to 50% as stated by FIGO. So the clinical understanding or underestimation of blood loss by 30 to 50% with accurate measure, early recognition will lead to better outcome. Timely recognition save life, where delay recognition cost life. There is several methods of estimation of blood loss. Method of estimation of blood loss can be visual estimation, which is the least accurate and prone to 30 to 50% of underestimation. Quantitative blood loss recommended by ACOG and FIGO, a combination of volumetric and gravimetric method yielding the best accuracy. Weigh soaked material before and after use. The formula is 1 gram equal to 1 ml of blood. So if you weigh the material and you find that there is an excess of 50 grams, that means it is 50 ml of blood. Use for pads and sponges and linen. Quantitative method or volumetric method use calibrated drop, which is automatically calculating the amount of difference in weight. Measure blood in suction container and subtracting the amniotic fluid and irrigation volume. We discussed the metric indicators, and now we are going to talk about the clinical indicator of significant blood loss. Hypodynamical sign like maternal tachycardia of heart rate more than 100 beats per minute, or hypotension where systolic blood pressure less than 90 millimeter mercury or mean arterial blood pressure less than 65 millimeter mercury, tachypnea with respiratory rate more than 20 beats per minute. These signs may appear early before the large volume of blood are lost. There is a physical sign like pallor in the skin, the mucous membrane, altered mental status, anxiety, confusion, agitations, drowsiness, or cold extremities, calmy skin with prolonged caliber refilling. This is reflected reduced perfusion and compensatory mechanism, where laboratory indicator with lactic acid more than 4 millimole per liter indicated tissue hypoperfusion and inadequate oxygenation delivery. Base deficit more than 6 reflected metabolic acidosis due to significant blood loss and poor perfusion. Abnormal lab supporting severity and assessments and guided resuscitation. Combine the clinical sign with a quantitative blood loss for timely diagnosis and intervention led to early recognition and saved lives. The current user definition of postpartum hemorrhage 2025-2026, different organizations define postpartum hemorrhage in different way, where ACOG define it as a cumulative blood loss more than 1000 ml or blood loss associated with sign or symptom of hypovolemia within 24 hours after birth, regardless of mode of delivery. The WHO define it as more than 500 ml after vaginal and more than 1000 ml after cesarean section within 24 hours of postpartum. Royal College of Obstetric Gynecology define it as minor, it is 500 to 1000, major more than 1000, and moderate between 1000 and 2000, severe more than 2000. FIGO, supportive objective quantitative blood loss, and emphasize early recognition of based on the measured blood loss and the clinical condition rather than waiting for large volume bleeding. So which one you want to follow? I would go with the one which we can calculate, and we'll see in the next slide. What is the shock index? Do you have any clue about the shock index, how the shock index is used in the management of postpartum hemorrhage? Shock index is heart rate divided by systolic blood pressure, when normal adult shock index is 0.5 to 0.7. Before we proceeding and explaining for you how is the shock index and is used in the postpartum hemorrhage and how it is important, we are going to tackle a little bit of physiology. Physiology and pathophysiology. During pregnancy, there is increase in the plasma volume by 40 to 50%. Increase in red blood cell mass by 15 to 25%. When total maternal blood volume expansion occurs, total maternal blood volume increased by 30 to 50% during pregnancy, which equal to 1.5 liter, 1 to 1.5 liter by late third trimester, which is from 4.5 before pregnancy to 5.5 to 6 liter at the third trimester. How this is going to affect the detection of postpartum hemorrhage? Here, why shock index is important in the postpartum hemorrhage. Because blood pressure may remain normal in early hemorrhage due to pregnancy physiology, and shock index raised before the hypotension appear. Incorporating shock index into postpartum hemorrhage protocol, improving the early recognition and rapid escalation. Classification of postpartum hemorrhage by severity into mild, moderate, severe, and massive postpartum hemorrhage. We are going to classify it according to what have been traditionally classified as blood loss. So if the blood loss between 500 to 999 ml, we will call it mild postpartum hemorrhage, and it will be presented by tachycardia. And if the blood loss between 1000 and 1499, we will call it moderate blood loss, moderate postpartum hemorrhage, and we call it tachycardia, where the patient will be presented by tachycardia and tachypnea. In severe cases, the blood loss will be more than 1500 and the patient will be presented by hypotension and confusion, where massive blood loss, if the blood loss more than 2 liter, more than 50% of blood volume lost within 3 hours, or need for more than 4 units of backed red blood cell within 1 hour. We call it profound shock. So looking to this traditional classification or traditional definitions of mild, moderate, severe, massive, that is rely on correlating the vital sign to the amount of blood loss. But actually, there is difference between a patient who is cardiac patient who is anemic petite, and the patient who is big and with 100 and more weight, with no fit and with no medical diseases, no anemia. So it's better to use the shock index because shock index is individualizing the situation. So the shock index was telling you when it is mild, when it's moderate, when it's severe, according to the patient situation by its. Look to this picture and you can see the shock index, which is heart rate divided by systolic blood pressure. And it will tell you this is mild, this is moderate, this is severe, and it tell you that there is also massive blood loss. And it can classify each one of this in different way. So the heart rate divided by systolic blood pressure, it is the soul, or it is the shock index which we are going to follow. Usually the shock index shouldn't exceeding 0.7. If it's exceeding 0.7 but less than 0.9, that there is mild bleeding, and usually the patient is stable and the circulation is compensated. All what you have to do is resuscitation and do medical management for the patient. If it is 0.9 to 1.3, then the patient start to be in early shock, and the patient will have tachycardia and start to have falling in the blood pressure, still continue resuscitation and medical management. Moderate, it is more than 1.3 and it is significant and reduced perfusion and need to act and urgent intervention, start to prepare, informing the anesthesia, informing the consultant if not yet informed, where I prefer the consultant to be involving in the postpartum hemorrhage from the beginning, so they will be ready and they will approach the healthcare organization if they are not in-house. Severe shock, the shock index will be more than 1.5, high risk, decompensation, and end organ injury. And we are starting with a massive blood transfusion protocol, shifted the patient to the OR to do surgery. If the shock index more than 1.7 to 2, this is profound shock, and this is most probably occurring in the cases of placenta previa or with acute abruptio placenta. So impending cardiovascular collapse and require immediate massive transfusion and surgical control, and massive blood transfusion, and proceed for surgery. Delaying surgery and thinking about resuscitating the patient first without intervening, this is you might lose the patients. So accurate definition, going with the shock index. If you have the shock index 1.5, shift the patient to the OR. There is no time to, okay, you start, you resuscitate, you do what you have to do. But if the patient see need to go for surgical intervention, then go for surgical intervention. Because if the patient went beyond 1.7, that means the risk of death is high. Thank you for your commitment to excellency in women healthcare. Together we are shaping safe care, improving outcome, and supporting every woman at every step. Here is the reference which I use in the reference for the lecture.